I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Thank you. I'd like to go on now to the second question. Dr. Lenard, I think we have an hour to do the rest of it, and I apologize. This is now, what are the risks and adverse effects of ECT? This is now, what are the risks and adverse effects of ECT? Dr. Squire. There is not any, I would suggest that you do sit down and raise your hand, because queuing up the microphone will not yield a reinforced response, so I can't do that way. You've got to go to try to cover the people who present material. I will try to get as many people as I can. Standing the microphone will not help you with this.
I'd like to address my comments to page 8. I think there's an ambiguity in all the steps of memory functions, which we need to be as precise about as we can. In other words, one needs to be uncomfortable with the term that there are transient memory deficits after ECT, because after all, there is this permanent gap, and one needs to be uncomfortable with the term that there are persistent memory deficits because of the implication that there is a permanent loss of the learning ability. And so with that idea in mind, I have several specific comments about the wordings on various parts of page 8. In the first paragraph, beginning depressive disorders, there's a sentence that reads, deficits in memory function which have been demonstrated objectively and repeatedly persist for several months after the termination of the normal course of ECT. This ambiguity has a chance of being resolved in the lower paragraphs, and I would think it might be easier and clearer at that point just to simply say deficits in memory which have been demonstrated, etc., persist after the termination of the normal course of ECT, rather than getting the timing of it, which becomes complicated. And similarly, in the same paragraph, greater deficit occurs from bilateral placement than from unilateral placement, but unilateral treatment may be less effective. I think that much more needs to be said about bilateral.
Dr. Squire, could you decelerate the pace?
Oh,
You can't write that fast.
It's not just 2 minutes then.
No, we are trying, this is a different, I'm sorry to make that clear. No, we're trying to allow for longer so that people can give us the benefit of their input.
Excuse me. I would be more comfortable if at that point there was no reference to the issue of but unilateral treatment may be less effective. Perhaps something like C page 15 or something, because I'm going to have some more standard comments about bilateral and unilateral ECT when we discuss point 4, and I think that to state it in that simple way is going to be a little misleading, because I think the unilateral bilateral issue is one that again needs to be fleshed out and spoken about with a little more precision. Now becoming more concrete. My recommendation would be to delete the end of the sentence which says but unilateral treatment may be less effective, or to insert simply a parenthesis saying see page 15 for discussions of differences between bilateral and unilateral treatment. Now, it's becoming more concrete in terms of the last 5 or 6 lines of the page. The first
3 to 4 lines are not a misstatement of that paragraph?
No. The last 4 or 5 lines of the page, what I thought I might do is just read an alternative version. Maybe that would be the simplest, and I'd be happy to I'll read it slowly. Beginning with a sentence, many patients complain. I would perhaps say it this way. Many patients complain that their memory is not as good as it was formerly for as long as 3 years after treatment, period.
This is what we have. That's just the same sentence we have.
With a period after the parentheses. A persisting deficit in new learning ability has not been established by neuropsychological testing. Period. Neuropsychological data are consistent with the existence of a persisting gap in memory around the time of treatment for a period of up to a few months after treatment and for a time of at least a few weeks before treatment. The exact periods of time persistently affected before treatment are not yet established with certainty. And then finally, read that sentence one more time.
Why don't we get it?
I'll write it out. And then finally, the last sentence, there is no consistent evidence of change in other cognitive functions such as attention. But I wouldn't use the term learning. Learning, of course, is the beginnings of memory. And in fact, learning and memory are exactly what is affected. So it would not, I think, be appropriate to use the term learning there. And then finally, I wonder if I might at this point speak to page 18 in which in your summary statement, you're speaking again about the memory effects and the same ambiguity about persistent, what's persistent, what's transient comes up in the first paragraph of page 18. Second sentence. You might flesh it out in the following way. There are, however, significant side effects, especially acute confusional states, memory dysfunction for up to a few months after treatment, and persistent memory deficits for the time around treatment.
Thank you very much. That reminds me, if any of you have any written statements about the consensus document you'd like to submit them, please feel free to do so.
One electroshock treatment can equal the energy of 3 pistol shots to the head.
Dr. Rose accepted 2 pieces of literature for reference. I would hope you might make copies available for the panel. We're talking about having at least accurate information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. The other, and pardon me for the emotional content of it, I've also included a current Winchester ammunition catalog because it shows the energy with which the bullets have. Now that's emotional. I don't really want to bring that up. But running this machine at its maximum brings 201 joules of energy. That is 148 foot-pounds. If you're interested in actually understanding, like the truth in lending and what they're talking about, 1 joule is 0.07376 foot-pounds. But what this means is this device, when operated at its maximum capacity, will lift a 1-pound weight 148.7 feet. The energy contained in that is equivalent to 3 25 caliber pistol slugs. Now that's almost instantaneous entering the brain. This takes a half a second. Now that is just pure factual data. To give that lifting of 1 pound energy equivalence in informed consent, how could you not do that? And if you're going to give a procedure, the total energy and the total time are the physical parameters that characterize the device. How could you not include that information? And if a doctor prescribes a drug, he has to record the prescription. Why isn't the total time and the total energy recorded? This has been an experimental hazardous device for years now. Why hasn't this information been gathered that we could be talking with concrete objective facts rather than subjective opinions of psychiatrists and patients?
One electroshock treatment can equal the energy of 3 pistol shots to the head.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it. That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.